So good morning everyone, my name's Bronte, I'm a third year medical student and today I'll be talking to you about hip fractures. Here is a brief outline of the talk today. I'll be touching on the epidemiology of hip fractures and briefly touching on the anatomy of the hip. Then we'll talk about the different types of hip fractures, how we manage them, and then finish up with the complications and prognosis of hip fractures. So starting off with the epidemiology of hip fractures, these are relatively common in Australia. It's estimated that around 19,000 hip fractures are hospitalised every year for patients over the age of 50. And of these hip fractures, the majority of them, so just over half, are neck of femur fractures. And I'll go over the different types of fractures in a little bit. So because the majority of hip fractures affect people aged over the age of 65, we are expected to see an increase in the trend of hip fractures given Australia's ageing population. So the majority of these hip fractures are related to fall-related injuries. So this really emphasises the importance of falls prevention and management. The majority, or around half of these hip fractures occur in patients' private homes and more than a quarter occur in aged care facilities. And we know that there are certain population groups that are at a greater risk of hip fractures. This includes elderly patients, women, people from Aboriginal and Torres Strait Islander backgrounds, people who live rurally and remotely and are from a lower socioeconomic status. So certain risk factors have been shown to increase the risk of hip fractures. The major one being osteoporosis, and this is especially so in postmenopausal women. And then you have other risk factors that can increase your risk of falls. So this includes muscle weakness, difficulty walking and impaired coordination, and you've got a few other risk factors that are listed there. Oh, can't go back. Okay, so as I was saying, the medial circumflex femoral artery supplies most of the hip joint, and if we have certain fractures, such as displaced intracapsular fractures, this can disrupt this blood supply and lead to avascular necrosis of the femoral head. And patients with these types of fractures will need to have a hip replacement rather than fixation, but I'll talk about the management a little bit later. So there are different types of hip fractures and they can broadly be classified into intracapsular and extracapsular. Intracapsular hip fractures involve fractures of the femoral head or the femoral neck. And then we have extracapsular hip fractures, which can be classified into trochanteric, intertrochanteric, and subtrochanteric. So we'll just briefly go through all of those different types of hip fractures. Starting off with the intracapsular hip fracture, one of the more uncommon hip fractures is the femoral head fracture. This accounts for only about 1% of all hip fractures, and it's often associated with a posterior hip dislocation following a dashboard injury as seen here. This happens in around 5 to 15% of posterior hip dislocations. Clinical features of these types of hip fractures includes groin pain, the inability to bear weight, and also local swelling. And just be mindful that these hip fractures can be classified using this Pipkin classification system, which you can read through in your own time. In terms of diagnostics, we can do an AP pelvis and lateral hip x-ray, and some features that we may see on this is abnormal trabecular pattern, cortical defects, shortening and angulation of the femoral neck. And you can do an MRI if there is any sort of diagnostic uncertainty. So we can see an example of a femoral head fracture here in this schematic and also in the x-ray denoted by the arrows. Moving on to one of the most common types of hip fracture, the neck of femur or Knopf fracture. This one's mechanism of injury is mostly in the elderly population that falls on a lateral hip, as you can see in this photo here, or falling on a twisting mechanism on a planted foot. It can also occur in young patients in high energy trauma situations such as an MVA or a fall, and also has been associated with insufficiency fractures as well. And an important thing to note about this type of fracture is that it can often be associated with fracture dislocations. So this happens if when the injury occurs, the hip is adducted. However, if the hip is abducted at the time of injury, you just get the femoral neck fracture. Clinical features of this type of fracture involve sudden onset hip pain in a displaced neck of femur fracture. However, in stress or insufficiency fractures, you just get a slight pain that may refer to the medial thigh and knee. On examination, the patient's leg is usually shortened and externally rotated in a displaced hip fracture, and this is due to the unopposed action of the iliopsoas muscle, and you can see that in this image here. So the neck of femur fractures can also be classified depending on their anatomical location. If you look at this image up the top here, they can be classified as subcapital, transcervical, or basicervical. And then within this transcervical fracture population, they can be further subclassified using this Garden classification system. And this classification system can be really useful in telling us the risk of avascular necrosis. So what do I mean by that? Well, I find it most useful just looking at the schematic here. If you have Garden 1 or 2 classifications, these are fractures that are typically non-displaced. So there's a lower risk of avascular necrosis, if you remember me talking about the anatomy on the previous slides. Garden 3 and 4 classifications are partially or entirely displaced, and these infer a higher risk of avascular necrosis. And you can see the corresponding X-ray images there as well. So what are we going to see on an AP pelvis X-ray of these types of fractures? Well, we can see disruption of Shenton's line, which I also spoke about before. We can see this loss of contour. We can also take a look at the lesser trochanter. Generally, it's more prominent than the other side, and that's due to the external rotation of the femur. As I mentioned, the femur is often positioned in that flexed and external rotation position. It's also important to look at the asymmetry between the two sides. You also may see sclerosis in the fracture plane, which you can see in this image here. And you may also see bony trabeculae that are angulated. And once again, with this fracture, you can do an MRI, CT, or nuclear medicine bone scan if you are worried about an occult fracture. So now we're moving on to the extracapsular fractures. One of the most common ones are the intertrochanteric fracture. So the mechanism of injury of these ones in elderly people are low energy falls in osteoporotic patients. There was actually a patient yesterday that presented with this type of fracture, and she was osteoporotic. And once again, in young people, it can be associated with high energy traumas. Clinical features involve swelling, pain of the hip, and a shortened externally rotated leg. And diagnostically, on an AP pelvic X-ray, we will see a proximal femur fracture between the greater and the lesser trochanter. So you can see that here denoted by the purple arrows. And just know that there's lots of different ways that you can classify these types of fractures, and that depends on the amount of fragments and also the stability of the fracture. And then the final type of extracapsular fracture is the subtrochanteric fracture. So these are fractures that are going to occur below the lesser trochanter, up to 5 centimetres below that distally. Mechanism of injury for these types of fractures are once again low energy falls in the elderly, high energy traumas in the young, but also note that pathological or atypical femur fractures, particularly bisphosphonate use, can occur in these sorts of fractures. Clinical features once again involve pain, swelling, shortened and externally rotated leg. And if we are looking at the AP pelvis X-ray, we can see that there is a fracture between the lesser trochanter and up to 5 centimetres below that distally. Looking specifically at the proximal fragment, you can see that it is flexed and abducted, and that's shown on this schematic here as well. And if we're looking specifically at the distal fragment, that's generally adducted and externally rotated. You can have a look at that one in your own time to figure that out. Okay, so how do we manage these patients? So initially, if you have a patient coming into ED with a suspected hip fracture, you want to provide them with analgesia, potentially paracetamol, opioids, or a nerve block. You want to gain IV access for fluid resuscitation to take bloods, also to administer medicines, and also assess and manage any potential complications to prevent delays in surgical management. So that can involve anticoagulating your patient, infection prophylaxis, etc. So in terms of management, we can either do surgical or non-surgical management. For surgical management, it's ideal to have this within the first 48 hours of the patient presenting to the hospital. And what sort of surgical management we do depends on the type of fracture, also who the patient is, how old they are, any comorbidities that they have. There are lots of benefits of early surgery, which are listed there. But not all patients will qualify for surgery, so non-surgical management may also be important in patients that are too unwell to undergo surgery, or if any patients decline surgery. So what can we do? There's lots of surgical management strategies, and these very much so depend on the type and the severity of the fracture. that could really be a whole talk in itself. So I've just briefly summarised the major ones here. For intracapsular fractures, generally in younger people, we do try to preserve the femoral head as much as possible. And then you can do an open reduction and internal fixation. So you can insert a cannulated screw fixation, which is this image here. You can insert a sliding dynamic hip screw, which is the second image here. And in older patients, generally you'll have to opt for a total or hemi hip arthroplasty. So here is the hemi arthroplasty, where you have replacement of the femoral head with a prosthetic. And in a total hip arthroplasty, you have replacement of the femoral head and the acetabulum as well. And then for extracapsular fractures, there are a few different management options, the main one being an intramedullary hip screw, which is the middle image here. So just to finish up, what are the complications of hip fractures and what's the prognosis? In terms of complications, the main one that I touched on earlier was avascular necrosis of the femoral head, and that occurred in those displaced intracapsular fractures. You can also have other complications related to the surgery itself, functional complications including nerve vessel damage, muscle ligament damage, and also complications specifically related to arthroplasty. In terms of prognosis, this really does depend on your patient, how old they are, what their health status is, and the type and the severity of the fracture. But I thought I'd just include in the most recent Australian statistics of the annual mortality of hip fracture, which is sitting at around 23%, and the 5-year mortality is sitting at around 55%. And that is my talk. Thank you very much.